Good afternoon, dear students. Today we start our lectures and with topic differential diagnosis and management of patient with anemic syndrome. Anemia is a hemoglobin level 2 standard deviations below the mean for the age and sex of the patient. Reference ranges vary between laboratories. The World Health Organization defines anemia as hemoglobin less than 11 gram in deciliter in pregnant women, less than 12 gram in deciliter in women age over 15 years, less than 13 gram in deciliter in men age over 15 years. The American Society of Hematology defines anemia as less than 13.5 gram deciliter in men and less than 12 gram in deciliter in women. Anemia is the most common hematologic disorder seen in general medical practice. The most common cause internationally is iron deficiency. Anemia can cause significant morbidity in left untreated and is often the presenting sign of a more serious underlying condition. The rate at which anemia develops is often as important as the severity, as a rapid decline can overwhelm the compensatory mechanism of the body. Erythropoiesis takes place within the bone marrow and is controlled by the stromal network, cytokines, and the hormone erythropoietin. Through a series of differentiation steps, hematopoietic stem cells become reticulocytes, red blood cells, with an intact ribosomal network. Reticulocytes remain in the bone marrow for 3 days before being released into the circulation. After one further day in circulation, reticulocytes lose their ribosomal network and become mature red blood cells, which circulate for 110 to 120 days before being removed from circulation by macrophages. Anemia develops when the rate of red blood cells production decreases and or rate of red blood cells loss increases. The most clinically useful classification system is based on the mean corpuscular volume. Microcytic anemia, normocytic, classified according the reticulocyte count as hyperproliferative, reticulocyte count more than 2%, the proportion of circulating reticulocyte increase as part of a compensatory response to increased disruption of loss of red blood cells. The cause is usually acute blood loss or hemolysis. Hypoproliferative reticulocytes count less than 2%. There are primary disorders of decreased red blood cells production, and the proportion of circulating reticulocytes remains unchanged. And macrocytic, classified as a megaloblastic, a deficiency of DNA production or maturation resulting in the appearance of large immature red blood cells, megaloblasts, and hypersegmented neutrophils in the circulation. And non-megaloblastic encompasses all other causes of macrocytic anemia in which DNA synthesis is normal. Megaloblasts and hypersegmented neutrophils are absent. This morphological classification of anemia in scheme. Anemia occurs when the production of red blood cells is decreased. the destruction of red blood cells is accelerated or there is a loss of red blood cells due to bleeding. In many cases, a combination of this mechanism is present. Risk factors include extremes of age, female sex, lactation, and pregnancy. Nutrient deficiency, acquired bone marrow disease, drugs, toxins, chronic systemic diseases, and genetic diseases may all lead to reduced red blood cells production. The resulting anemia can be macrocytic, hyperproliferative, normocytic, or microcytic, depending on the cause. Microvascular disease, infection, drugs, and genetic disorders may cause hemolytic anemia. Hemolytic anemias are a group of anemias resulting from increased destruction of red blood cells with a resultant increase in circulating indirect bilirubin. The resulting anemia can be microcytic or hyperproliferative normocytic depending on the cause. Acute hemorrhage causes a normocytic anemia and reticulocytosis occurs within 6 hours of the onset of bleeding. By contrast, chronic slow bleeding causes microcytic anemia due to ongoing iron loss leading to deficiency. Iron deficiency anemia, the most common cause of worldwide. The information of a heme moiety in hemoglobin, myoglobin, and cytochrome requires iron. Inadequate intake or absorption of iron or excessive iron loss lead to microcytic anemia. Signs of iron deficiency include chylomicria, angulohylosis, glossitis, and thinning hair. Inadequate iron intake, red meat provides the main source of heme iron, and iron deficiency is common in geographic regions where meat is sparse and there is poor dietary iron intake. Other sources of heme iron include white meats, fish, and seafood. Vegetarians are more prone to iron deficiency anemia because plants provide non-heme iron that is less readily absorbed. Beans, nuts, dried fruit, broccoli, and spinach are sources of iron. Iron malabsorption occurs due to achlorhydria, gastric surgery, chronic pancreatitis, gallstones, destruction of small bowel absorptive area in chronic disease such as celiac disease, intestinal wall edema in heart failure, or following extensive resection of the proximal small bowel. Excessive iron loss, gradual prolonged bleeding due to any cause produced iron depletion because 2/3 of the total body iron is contained in circulating hemoglobin. Menstruation and gastrointestinal bleeding are the most common causes. Hemoglobinuria, iron loss in the urine, is rare. The usual cause is paroxysmal nocturnal hemoglobinuria, but hemoglobinuria can occur following rapid intravascular hemolysis of any case. Vitamin B12 deficiency. Vitamin B12 is an essential cofactor in DNA synthesis, which is obtained only from the diet or by supplementation. Vitamin B12 deficiency. Dietary sources include animal and dairy products such as meat, poultry, milk, and eggs. Deficiency produces neurologic disorders and megaloblastic anemia. Decreased dietary intake may occur in chronic malnutrition, alcohol misuse, and strict vegan diets. Diminished breakdown of dietary vitamin B12 may be due to pernicious anemia, previous gastric or intestinal surgery, or atrophic gastritis. Malabsorption occurs in gastric malabsorption, Crohn's disease, celiac disease, and bacterial overgrowth. Folate deficiency. Folate is an essential cofactor in DNA synthesis, which is obtained only from the diet or by supplementation. Dietary sources include green leafy vegetables, citrus fruits, and animal products. Deficiency produced a range of signs including aglositis, angular stomatitis, patchy hyperpigmentation of the skin and mucous membranes, persistent mild pyrexia in the absence of infection, and megaloblastic anemia. Common causes include decreased dietary intake, chronic malnutrition, alcohol misuse, dietary restriction of protein intake, impaired absorption, achlorhydria, celiac disease, tropical sprucing deficiency, bacterial overgrowth, and increased folate requirement infancy, pregnancy, lactation, malignancy. Patients with vitamin B12 deficiency can have excessive renal folate excretion. Similarly, chronic alcohol misuse can lead to excessive biliary folate excretion. Rarely, hypothyroidism and congenital enzyme deficiencies may impair folate metabolism. Generalized malnutrition often causes iron deficiency. Patients often have associated vitamin B12 and or folate deficiency, in which case the resulting anemia is normocytic. Associated copper deficiency is rare, but should be considered in patients on prolonged total parenteral nutrition. Acute hemorrhage. Any acute hemorrhage can cause a normocytic anemia. Reticulocytosis is seen within 6 hours on the onset of bleeding. By contrast, chronic slow bleeding leads to ongoing iron loss and produces a microcytic anemia due to iron deficiency. The most common causes are trauma, including gunshot wounds, major fractures, or crush injuries, acute gastrointestinal bleeding, rupture of a vascular aneurysm, especially abdominal aortic aneurysm, and recent surgery. Patients are at increased risk of hemorrhage if they are taking anticoagulant therapy, have an underlying defects in hemostasis, or have a consumptive or dilutional coagulopathy following repeated blood transfusions. Gradual prolonged bleeding. Bleeding due to any causes produce iron depletion. Excessive menstrual losses are a common cause in females. The gastrointestinal tract is a common site of bleeding. Common causes include hemorrhoids, salicylitis ingestion, peptic ulcer disease, hiatal hernia, diverticular disease, neoplastic disease, and ulcerative colitis. Hookworm infection in developed countries, but is a significant cause of iron deficiency anemia in low and mild income countries. Rare causes include cow's milk allergy in infants, Meckel diverticulum, schistosomiasis, trichuriasis, and hereditary hemorrhagic telangiectasia. Rare sources of blood loss from other sites include pulmonary bleeding, seen in idiopathic pulmonary hemosiderosis and Goodpasture syndrome, blood donation, and self-harm. In addition, any underlying disorders that impairs hemostasis increase the risk of bleeding and iron deficiency anemia. Anemia of chronic disease usually causes a mild hyperproliferative normocytic anemia. Coexisting iron deficiency produced a microcytic anemia. It is caused by chronic inflammation. Pro-inflammatory cytokines, especially interleukin 6, trigger a cascade of events mediated via upregulation of hepcidin that decrease red blood cells production by lowering serum iron and erythropoietin levels, and increase red blood cells destruction by stimulating erythrophagocytosis and oxygen-free radical formation. Common underlying processes include infection, neoplasms, autoimmune reaction, and injury to tissue from trauma or surgery. These underlying processes may coexist. Chronic kidney disease produce a normocytic or microcytic anemia. The etiology is complex and multifactorial. Decreased erythropoietin production, accumulation of erythropoiesis inhibitors, and secondary hyperparathyroidism all contribute. Chronic blood loss, inflammation, and nutritional deficiency cause an iron deficiency anemia. Patients often need to reduce their protein intake, which lead to decreased meat in the diet and poor iron intake. Poor iron absorption may also occur. Erythropoietin therapy and chronic inflammation can cause functional iron deficiency produced by an inability to mobilize iron stores effectively. Chronic liver disease. A mild to moderate non-megaloblastic microcytic anemia is produced by a combination of intravascular dilution due to volume overload, increased red blood cell destruction, and impaired bone marrow compensatory responses. High hypothyroidism, a cause of mild hyperproliferative normocytic anemia due to the loss of the stimulatory effect of thyroid hormones on erythropoiesis. Heart failure. Up to 1/3 of patients with heart failure have anemia. Anemia of chronic disease, iron deficiency, hemodilutions, and adverse effects of medication may all contribute. Inflammatory bowel disease. Anemia associated with inflammatory bowel disease is often due to a combination of iron deficiency and anemia of chronic disease. Hypogonadism. Testosterone increases production of hematopoietic growth factors and iron bioavailability, and primary hypogonadism may cause anemia in older men. Malignancies. Patients with cancer are up to 5 times more likely to have anemia compared with healthy age-matched population. Folate, B12, serum iron, and transferrin saturation were lower, but ferritin, which is an acute phase reactant, was higher in cancer patients compared with controls. Anemia was more prevalent in metastatic than non-metastatic disease. Myelodysplastic syndrome, a heterogeneous group of clonal stem cells disorders, uncontrolled proliferation and clonal expansion of neoplastic multipotential hematopoietic stem cells compromise the production of normal cells, producing a range of cytopenias, usually due to acquired chromosomal abnormalities, but can be caused by chemotherapy or radiation therapy. The anemia is a non-megaloblastic microcytic anemia, but the peripheral blood smear may show hypersegmented neutrophils similar to those seen in megaloblastic microcytic anemias. a normal random distribution of red cells in the setting of microcytic anemia in an older adult should raise this suspicion. Leukemias: acute lymphocytic leukemia, acute myeloid leukemia, and chronic myelogenous leukemia are caused by the uncontrolled proliferation and clonal expansion of abnormal progenitor cells. This disease affects progenitor cells at different stages of the differentiation process, but all cause anemia by compromising the production of normal red blood cells. Infiltration of the bone marrow by secondary malignancy. Metastasis of solid tumors to the bone marrow can cause anemia by infiltration of the marrow space. Any tumor can metastasize to the bone marrow, but the most commonly seen are neuroblastoma in children and breast, prostate, and lung cancer in adults. Metastasis to the bone marrow is a poor prognostic sign. Aplastic anemia, a disorder of stem cells failure leading to pancytopenia in the absence of splenomegaly, can be due to an inherited bone marrow failure syndrome or acquired, induced by the variety of disorders like autoimmune or toxic, where immune mechanism with local activation of interferon gamma may be a common etiologic pathway. Affected patients typically present with recurrent infection due to neutropenia, bleeding episodes due to thrombocytopenia, and less often fatigue due to anemia. Toxic causes include benzene, diprion, chloramphenicol, penicillamine, and gold. Definitive diagnosis is established following bone marrow aspiration and biopsy. Pure red cells aplasia, caused by congenital or acquired impairment of erythroid progenitor cells. Acquired form can be self-limited or chronic. Self-limited acquired disease can be caused by infection or medications. The most common infection cause is parvovirus B19. Other infection causes include infection mononucleosis, viral hepatitis, malaria, respiratory infection, gastroenteritis, primary atypical pneumonia, and mumps. Certain medication exert a toxic effect on erythroid progenitor cells that is irreversible once the medication is discontinued. Examples include phenytoin, carbamazepine, sodium valproate, azathioprine, chloramphenicol, sulfonamides, isoniazid, and procainamide. Chronic acquired disease is caused by autoimmune disease, for example, systemic lupus erythematosus, rheumatoid arthritis, dermatomyositis, polyarteritis nodosa, scleroderma. Persistent infection, persistent parvovirus B19 infection in immunosuppressed patients, chronic active hepatitis, and timomas. Congenital forms are produced by in utero damage of erythroid progenitor cells. The cause is unknown. Drugs may cause anemia through multiple mechanisms, including immune mediator or direct red blood cells hemolysis, interference with DNA synthesis, impaired absorption metabolism, or action of important DNA synthesis cofactors, or a toxic effect on progenitor cells in the bone marrow. Hemolytic anemia common culprits include penicillin, methyl-dopa, levodopa, quinidines, cephalosporins, and some non-steroid anti-inflammatory drugs. Drugs that directly interfere with DNA synthesis include purine analogs, pyrimidine analogs, and ribonucleotide reductase inhibitors. Drugs that affect DNA synthesis cofactors include methotrexate and trimethoprim, phenytoin, phenobarbital, and primidone, and palmaminosalicylate acid, metformin, colchicine, and neomycin. Drugs and chemicals that produce a toxic effect on a range of progenitor cells include benzene, chloramphenicol, penicillamine, and cold. Drugs that produce a toxic effect on erythroid progenitor cells producing pure red cell aplasia include anti-epileptic medication, azathioprine, chloramphenicol, sulfonamides, and azanazide, and procainamide. Drugs that inhibit erythroid stimulation and suppress erythropoietin production include ACE inhibitors and angiotensin II receptor blockers. Radiation exposure can produce a pancytopenia. Lead toxicity. Occupational or home exposure anemia can occur because lead competes with zinc, an important cofactor in heme synthesis. Some patients also have a concurrent iron deficiency anemia. Alcohol misuse. Long-term alcohol intake directly suppresses the bone marrow independent of any concurrent liver disease or vitamin deficiency. The effect resolves only after months of abstinence and may persist even after normalization of vitamin B12 and folate levels. Autoimmune hemolytic anemia. Red blood cells are attacked by antibodies and targeted for extravascular destruction. This usually occurs either as part of other autoimmune conditions, systemic lupus erythematosus, rheumatoid arthritis, or scleroderma, or in relation to lymphoproliferative disorders, usually non-Hodgkin lymphoma or chronic lymphocytic leukemia. Autoimmune disease can also cause pure red cells aplasia. Autoimmune hemolytic anemia can be caused by transfusion reaction, usually due to AB0 incompatibility. A range of infection can produce a hemolytic anemia, including cytomegalovirus infection, mononucleosis, and toxoplasmosis. Leishmaniasis produce combined red blood cells hemolysis, bone marrow suppression, and blood loss. Causes of pure red cell aplasia include pyrovirus B19 infection, mononucleosis, viral hepatitis, malaria, respiratory infection, gastroenteritis, primary atypical pneumonia, and mumps. Genetic disorders, thalassemia is a group of autosomal recessive genetic condition that results in decreased of or absence production of the alpha globin or beta globin chains of the hemoglobin molecule. The decrease or absent globin production results in impairment of erythropoiesis. Increased red blood cells destruction occurs, producing hemolytic anemia. Disease severity depends on the underlying mutations and range from asymptomatic to severe transfusion-dependent anemia with skeletal changes. Sickle cell anemia, a hemolytic anemia caused by an autosomal recessive single gene defect in the beta chain of hemoglobin, which results in sickle cell hemoglobin. Red blood cells containing sickle cell hemoglobin become rigid and are destroyed into a crescent shape. Patients are prone to episodes of vaso-occlusion due to the rigid deformed red blood cells and prothrombotic state created by the accompanying leukocytosis, which increase cytokine release. Persistent pain in abdomen, chest, or skeleton and dactylitis are the key presenting symptoms. Hereditary spherocytosis, a hemolytic anemia caused by an autosomal dominant inherited abnormality of red blood cells that produce defects in the skeletal proteins of the red cell's membrane. As a result, red blood cells lose their biconcave structure and become spherocytes. Spherocytes are fragile and are selectively removed and destroyed by the spleen. Increased red blood cell destruction leads to anemia with hyperbilirubinemia and splenomegaly. Decrease severity ranges from asymptomatic to transfusion-dependent anemia with jaundice depending on severity of the underlying membrane defect. Glucose 6-phosphate dehydrogenase deficiency, an inherited hemolytic anemia due to an enzyme deficiency that is common among population originating from parts of the world where malaria is or was common, such as sub-Saharan Africa, Asia, the Mediterranean region, and the Middle East. Glucose 6-phosphate dehydrogenase catalase a reaction that is linked to the generation of reduced glutathione. Red blood cells rely solely on reduced glutathione as an antioxidant defense, so deficiency of G6PD increased red blood cells destruction. The severity of this disease varies depending on the severity of the underlying mutation. Most patients are asymptomatic. Symptomatic disease produced episodes of acute hemolysis with pallor and jaundice following exposure to oxidant stress. Triggers include fava beans, sulfur drugs, aspirin, nitrofuranate, naphthalene, and febrile illness. The resulting hemolysis is usually self-limited. Life-threatening symptoms are more common with the Mediterranean variant. Congenital bone marrow failure syndromes. Fanconi anemia is the most common. It's usually autosomal recessive, but can also be X-linked. Mutation in 13 genes have been identified. The genes code for proteins that form a nuclear complex involved in the DNA damage response. However, the precise mechanism by which the mutation produced bone marrow failure are not known. Microangiopathic hemolytic anemia are often considered as a group. They produce a hyperproliferative normocytic anemia. The underlying disease process produces endothelial damage and activates the coagulation cascade, leading to fibrin deposition on the damaged endothelial surface. In small vessels, the endothelial fibrin causes mechanical fragmentation and shearing of red blood cells, leading to hemolysis. The irregular shaped red blood cell fragments produced by this process are called schistocytes and can be seen on a peripheral blood smear. Hemolytic uremic syndrome. Damage to the endothelium of the glomerular bed produce hemolytic anemia, thrombocytopenia, and nephropathy. Causes include verotoxins produced by Escherichia coli, neuraminidase produced by streptococcal species, inherited defects in protein that control complement, and drugs, cyclosporin, and some chemotherapy agents. Disseminated intravascular coagulation, an acquired syndrome produced by activating of coagulation pathways, resulting in the formation of intravascular thrombosis and the depletion of platelets and coagulation factors. Disseminated intravascular coagulation can be triggered by mild trauma, burns, organ failure, pancreatitis, acute liver failure, sepsis, or severe infection, severe obstetric disorders, malignancies, myelocytic leukemia, or metastatic mucin-secreting adenocarcinoma, myovascular disorders, and severe toxic or immunological reaction. Thrombocytic thrombocytopenic purpura, a clinical syndrome of microangiopathic hemolytic anemia and thrombocytopenic purpura, believed to be due to the production of abnormally large von Willebrand factors, multimers. The abnormal von Willebrand factors triggers aggregation of circulation platelets at sites of high intravascular shear stress, which in turn results in thrombi in the microvascular system. Thrombocytopenia is produced by excessive consumption of platelets. Purpura and other signs of bleeding appear in a small proportion of patients. Thrombus formation in the microvasculature also produce severe central nervous system symptoms and renal disease. Vascular tumor that occurs as a result of abnormal angiogenesis and overproliferation of blood vessels. These range from obvious superficial lesions to internal organ hemangiomas. A local consumptive coagulopathy can occur as a complication leading to thrombus formation and thrombocytopenia, sharing and fragmentation of red blood cells against the clots in the small vessels of the hemangiomas. Can lead to a hemolytic anemia. Sabach-Merritt syndrome can also produce DIC in severe cases. Malignant hypertension. Hypertensive emergency with systolic blood pressure more than 210 millimeters Hydrangeum and diastolic more than 130, associated with rapid deterioration of vital organ function. Common causes include untreated essential hypertension, renal disease, eclampsia, use of symptomatic drugs, and use of monoamine oxide inhibitors. This disease is more common in older people, males, and those of black ethnicity. Causes endothelial injury and endothelial fibrin dysfunction, mechanical red blood cells sharing and fragmentation resulting from high pressure and fibrin of the small vessels produce hemolytic anemia. Prostatic valves and surface. The shear stress and turbulence created by the foreign surface cause sharing and fragmentation of red blood cells. Improved prostatic have reduced the incidence of this complication, and the anemia, if it occurs, is usually mild. Pregnancy. Anemia in pregnancy is common worldwide. 38% of pregnant women are anemic. Pregnancy increases physiological demands on iron, which is needed for fetal brain and placental development. In addition, the plasma volume expands out of proportion of red blood cells mass, causing hemodilution. Iron deficiency in pregnancy is associated with an increased risk of maternal and perinatal morbidity and mortality. Anemia may be due to dilutional effect as the plasma volume expands out of proportion to red blood cells mass. Despite being an important problem in pregnancy that can be effectively treated, there is a lack of high quality evidence of the benefits of a national screening program for anemia in pregnancy in terms of reduced maternal and infant morbidity. Thermal burns. Patients with burns affecting more than 10% of the body surface area can develop hemolytic anemia due to intravascular hemolysis of red blood cells, loss of red cells mass due to thrombus formation, and damage to red blood cells from systemically released proteases and oxygen-free radicals. Hospital-acquired anemia. One onset anemia in hospitalized patient with previously normal hemoglobin. Hospital-acquired anemia is typically related to increased phlebotomy and iatrogenic blood loss from invasive procedure or hemodilution. Acute inflammatory response to illness, decreased compensatory erythropoiesis. Hospital-acquired anemia is associated with increased morbidity and length of hospital stay. Anemia may be microcytic. In this case, serum iron studies should be performed normocytic. The reticulocyte count should be explained to determine if anemia is hypoproliferative or hypoproliferative. And microcytic, the peripheral smear should be examined for megaloblasts and hypersegmented neutrophils. If these cells are present, the anemia is megaloblastic. If they are absent, this anemia non-megaloblastic. A low serum iron and elevated total iron binding capacity and a low ferritin indicate iron deficiency anemia. Serum ferritin is the most sensitive and specific test for iron deficiency. Iron deficiency produced an associated reactive thrombocytosis that provides an additional clue. Iron deficiency is not a diagnosis and requires further investigation to define the cause. Associated symptoms may indicate a source of chronic bleeding, for example, heavy menstrual bleeding, coffee, ground vomiting, hematemesis, melena, rectal pain, or rectal bleeding. Hemoptysis may indicate Gauss-Pacher syndrome or idiopathic pulmonary hemosiderosis. A history of dark colored urine may indicate paroxysmal nocturnal hemoglobinuria. Alcohol misuse and cirrhosis are associated with coagulation disorders and esophageal varices. Rarely, a history of excessive blood donation or self-harm may be elicited. Patients who are avid runners may have runner's anemia from repetitive mechanical trauma, also known as March hematuria. A history of gastric surgery, celiac disease, or extensive small bowel resection suggests malabsorption as the case. Pregnancy is the common cause of iron deficiency. Investigations are guided by the history and examination and include the following. Fecal occult blood testing, which should done in all patients and is positive if gastrointestinal bleeding is present. Upper gastrointestinal endoscopy, which should be performed in the is a history of upper gastrointestinal bleeding or a positive fecal occult blood test. It may identify source of an upper gastrointestinal bleed, peptic ulcer, disease, gastritis, esophageal varices, hiatus hernia, apical diverticulum, and increased gastric pH in achlorhydria. Following negative endoscopy, in the settings of persistent iron deficiency anemia, testing for Helicobacter pylori may be considered. Immunoglobulin A tissue Transglutaminase test should be performed in all patients and is positive in celiac disease. Colonoscopy, which should be performed if there is a history of lower gastrointestinal bleeding or a positive fecal occult blood test. An occult blood test may be reveal malignancy, diverticular disease, ulcerative colitis, or rarely causes such as hereditary hemorrhagic telangiectasia. United States and the United Kingdom guidelines report risk their shows for testing among low to average risk symptomatic population. United Kingdom guidelines recommend quantitative fecal immunochemical tests for patients who don't have rectal bleeding and are age 50 years and over, which an explained abdominal pain or weight loss, or age 60 years and under with changes in bowel habit or iron deficiency anemia, or ages 60 years and over they have anemia even without iron deficiency. Patients who have a positive quantitative fecal immunochemical test should be referred for an urgent appointment within 2 weeks through the suspected cancer referral pathway. Flow cytometry should be considered if there is a history of passing red urine or red blood cells results consistent with a hemolytic anemia. It detects decreased expression of red blood cell surface proteins and is diagnostic of paroxysmal nocturnal hemoglobinuria. Transvaginal ultrasound, which may reveal causes of hemorrhagia, including hyperplasia, dysplasia, fibroids, polyps, or malignancy. Stool microscopy, which may identify hookworm, whipworm, or schistosoma X. These should be performed if clinical features suggest the diagnosis of there is a history of travel or endemic areas. A low serum iron, a low total iron binding capacity, and a low normal ferritin suggest coexistence of anemia of chronic disease with iron deficiency. A history of underlying inflammatory process, infection, neoplasm, autoimmune reaction, and injury to tissue from trauma or surgery is usually present. Serum seroactive protein may be raised. A serum erythropoietin level should be controlled. The result is usually normal or mildly elevated. Ferritin is an acute fast protein and serum levels can rise and in inflammatory conditions. Liver disease and malignancy, even through iron stores are low. Hypothyroidism and vitamin C deficiency may produce a falsely low ferritin level. The most important cause to exclude is thalassemia, especially in areas where it may coexist with iron deficiency. A family history is usually present. The disease is more common in individuals of Mediterranean, Middle Eastern, or Southeast Asian descent. Hematological malignancies and aplastic anemia are the most important diagnosis to exclude and are usually associated with multiple cytopenias. And isolate anemia is usually due to pure red cell aplasia. Chronic kidney disease or hypothyroidism can also cause an isolated anemia. Normocytic anemia, normocytic hypoproliferative anemia. History: symptoms of bleeding, easy brushing, night sweats, or weight loss suggest hematologic malignancy or aplastic anemia. Inquire about symptoms and risk factors for infection, which can cause self-limited pure red cells aplasia, such as parvovirus infection, infection mononucleosis, virus hepatitis, malaria, respiratory infection, gastroenteritis, and mumps. Medication: phentermine, carbamazepine, sodium valproate, azathioprine, sulfonamides, as an azide and proguanimide can cause pure red cells aplasia. Benzene, penicillamine, and gold can cause aplastic anemia. Chloramphenicol can cause either aplastic anemia or pure red cells aplasia. Chemotherapy causes pancytopenia. Radiation therapy, especially to pelvic or sternal areas, can cause pancytopenia. A history of autoimmune disease or chronic hepatitis suggests persistent pure red cells aplasia. There may be a history of features of chronic kidney disease or hypothyroidism. Ecchymose or petechia due to thrombocytopenia suggests hematologic malignancy, myelodysplastic syndrome, or aplastic anemia. Lymphadenopathy or fever suggest malignancy or infection. Splenomegaly may be seen in hematologic malignancies. Massive splenomegaly may be seen in patients with high-risk leukemia. Initial investigation should be guided by the history and examination findings. CBC may show an associated cytopenia and characteristic changes specific to hematological malignancy. A pancytopenia suggests aplastic anemia or may be due to chemotherapy or radiation therapy. Is an isolated anemia suggests pure red cell aplasia or anemia due to chronic kidney disease. Bone marrow biopsy is required for the definitive diagnosis of acute leukemia, chronic myelogenous leukemia, aplastic anemia, or bone marrow metastasis. Antiparavovirus antibodies are positive in paravovirus infection. The most common infection cause of pure red cells aplasia. Other tests to consider: hepatitis serology to exclude acute or chronic active hepatitis, monospot tests, or Epstein-Barr virus-specific antibodies to exclude infection mononucleosis. Virus capsid antigen immunoglobulin M is detectable in most patients with symptom honest. Thick and thin peripheral smear to exclude malaria if history and clinical findings suggest the diagnosis. Thyroid function test. Thyroid stimulating hormone is elevated and free thyroxine reduced in hypothyroidism. Antinuclear antibodies, which are positive in systemic lupus erythematosus or scleroderma, rheumatoid factors, which may be positive in rheumatoid arthritis, serum creatinine kinase, which is elevated in dermatomyositis, erythropoietin levels, which may be inappropriately decreased in patients with chronic kidney disease, serum calcium and parathyroid hormone levels should be considered if associated secondary hypoparathyroidism is suspected. Chest X-ray, which may show infiltrate in atypical pneumonia or smooth mass in pneumoma. Potential diagnosis include hemorrhage and hemolytic anemia. Drugs can cause hemolytic include penicillin, methyldopa, levodopa, quinidines, cephalosporins, and some non-steroid anti-inflammatory drug. Cyclosporin, tacrolimus, clopidogrel, oral contraceptive pills, and some chemotherapy drug may cause hemolytic uremic syndrome. They may be a history suggestive of microangiopathic disease. Known triggers of disseminated intravascular coagulation include ongoing severe infection, sepsis, malignancy, obstetric emergency, trauma, burns, pancreatitis, liver failure, envenomation, drug overdose, and any cause of endothelial damage. The presence of acute honest neurologic symptoms, including headache, confusion, focal weakness, seizures, or coma, should prompt suspicion of thrombotic thrombocytopenic purpura. Female present may have associated menorrhagia. Sudden illness, dizziness, headache, mental status change, loss of sensation or motor strength, chest pain in or pressure, dyspnea or edema in patient with known hypertension should perform suspicion of malignant hypertension. A history of renal failure or eclampsia may also be present. And expanding vascular skin lesions in a young infant or child should prompt suspicion of hemangioma. A history of prosthetic valve replacement may indicate hemolysis induced by the prosthesis. Bloody diarrhea should prompt suspicion of Escherichia coli infection and hemolytic uremic syndrome. Persistent pain in the skeleton, chest, or abdomen, priapism, lower extremity skin ulcers, or acute pneumonia-like syndrome suggest sickle cell anemia. Patient with inherited hemolytic anemia such as sickle cell anemia, hereditary spherocytosis, or glucose 6-phosphate dehydrogenase deficiency may have a positive family history. There may be a previous history of autoimmune disease or lymphoproliferative disorders which can lead to autoimmune hemolytic anemia. Note that autoimmune disease may also cause pure red cell aplasia, in which case the reticulocyte count would be low with normal lactate dehydrogenase, haptoglobin, and bilirubin levels. Recent blood transfusion may indicate hemolysis due to a transfusion reaction. Occupational or home exposure to lead should prompt suspicion of lead toxicity. Examination. Features of microangiopathic disease. There may be purpura or ecchymosis due to bleeding, systolic blood pressure more 210 and diastolic more 130 indicate malignant hypertension. Associated signs may include new murmurs, third heart sound on auscultation of the heart, jugular venous distension, rails or lower extremity edema, oliguria or polyuria, focal neurologic signs, and hypertensive retinopathy. Cutaneous reddish brown or violaceous vascular lesions may indicate hemangioma. Splenomegaly is seen in hereditary spherocytosis. Clinical features of underlying autoimmune disease may be present. Lymphadenopathy may indicate infection, mononucleosis, leukemia, lymphoma, or autoimmune disease. Initial diagnosis. The red blood cells and peripheral smear should be examined for clues to the underlying cause, thrombocytopenia with schistocytes strongly suggest a microangiopathic hemolytic anemia. Spherocytes suggest autoimmune hemolytic anemia or hereditary spherocytosis. Hereditary spherocytosis is also associated with increased mean corpuscular hemoglobin. Cycling of red blood cells is diagnostic of sickle cell anemia, hence bodies centrocytes or bile cells and are seen in G6PD deficiency. In hemolytic anemia is suspected serum lactate dehydrogenase, haptoglobin, and bilirubin should be measured. Elevated lactate dehydrogenase and bilirubin levels with decreased haptoglobin are strongly suggestive of hemolytic anemia. Clinical jaundice is seen once bilirubin level rise above 2 to 4 milligram deciliter. Test to consider in suspected microangiopathic hemolytic anemia: serum creatinine, which may be elevated in patients with hemolytic uremic syndrome or malignant hypertension; urine dipstick, which may show hematuria or proteinuria in hemolytic uremic syndrome; stool tests, culture, polymerase chain reaction for enterohemorrhagic E. coli genus or enzyme-like immunosorbents assay for shigatoxin in hemolytic uremic syndrome. prothrombin time and activated partial prothrombin time, which are prolonged in disseminated intravascular coagulation, but normal is in other microangiopathic hemolytic anemias. DIC panel show elevated D-dimers and fibrin degradation products with low fibrinogen in patient with DIC. X-ray and magnetic resonance imaging screening of suspected region reveal internal hemangiomas. Tests to consider in other hemolytic anemia: direct antiglobulin, Coombs test, which is positive in autoimmune hemolytic anemia. Test to identify hereditary causes sickle cell anemia is diagnosed on CBC. Osmotic fragility test is positive in hereditary spherocytosis, cells lease and exposure of hyposmotic solution. G6PD assess identify deficiencies of the enzyme. Test to identify infection, monopost test or Epstein-Barr virus. Immunoglobulin M is positive in infection mononucleosis, cytomegalovirus. Immunoglobulin M is positive in cytomegalovirus infection, double sandwich immunoglobulin M enzyme-like immunosorbents assay, or immunoglobulin G avidity test is positive for immunoglobulin M in acute toxoplasmosis. Splenic or bone marrow aspirate show amastigotes of the parasite in leishmaniasis. Blood lead levels which are elevated in lead toxicity. The main causes to consider the vitamin B12 or folate deficiency, or drugs that interfere with DNA synthesis. Autoimmune thyroid disease may coexist with pernicious anemia and atrophic gastritis, which decrease B12 absorption. Therefore, screening for B12 deficiency when the etiology of hyperthyroidism is through to autoimmune is recommended. History. Poor intake due to malnutrition, alcohol misuse, or strict vegan or low protein diet can produce deficiency of vitamin B12 and or folate. A history of celiac disease, tropical sprue, Crohn's disease, previous gastric or intestinal surgery, or bacterial overgrowth may indicate malabsorption. Swollen red, painful tongue, angular stomatitis, patchy hyperpigmentation of the skin and mucous membranes, and persistent mild pyrexia are symptoms of folate deficiency. Non-causative medication include purine analogs, pyrimidine analogs, reductase inhibitors, methotrexate, trimethoprim, anticonvulsants, oral contraceptive, cycloserine, paminosalicylate acid, metformin, colchicine, neomycin, and biconides. Hydroxyurea in particular is known to cause oval macrocytosis with MCV more than 110 femtoliters. Initial investigation. When investigating microcytic anemia is determining the vitamin B12 levels is more relevant and cost efficient than determining folate levels. Serum vitamin B12 levels are decreased and serum methylmalonic acid levels are elevated in vitamin B12 deficiency. The latter is more sensitive and should be used to definitely exclude vitamin B12 deficiency. An MCV of more than 150 is typically seen in nutritional deficiency. Serum folate level are low in folate deficiency. If folate level are low, serum vitamin B12 and methylmalonic acid levels should be measured to exclude concurrent vitamin B deficiency before folate levels are corrected. Normal serum homocysteine levels make folate deficiency unlikely. Serum folate is rapidly affected by diet and short-term supplementation. Red blood cells folate represents longer-term body stores. In most cases, however, serum folate is preferred and correlated well with red blood cells folate. Anti-instructive factors and peritoneal cell antibodies are positive in pernicious anemia. All adult patients with chronic gastrointestinal symptom should be considered for celiac disease screening. Potential diagnosis cause to consider include alcohol misuse, myelodysplastic syndrome, chronic liver disease, and congenital bone marrow failure syndrome. Examination may reveal stigmata of chronic alcoholism or chronic liver disease. Pale, patchy, and purpura may be present in myelodysplastic syndrome. This keratosis congenita is characterized by the triad of abnormal nails, reticular skin rash, and leukoplakia. Investigation. Red blood CBC shows associated neutropenia and thrombocytopenia with microovulocytes in myelodysplastic syndrome. Bone marrow aspiration and biopsy shows myeloblasts with immature precursors in myelodysplastic syndrome. Diagnostic features of congenital bone marrow failure syndrome are also identified. Cytogenetics revealed chromosomal translocation in myelodysplastic syndrome. Additional tests for congenital bone marrow syndrome, deoxybutan or beta-methyl C fragility test is positive in Fanconi anemia. Genetic testing reveals underlying mutation. Differential or reuse. Iron deficiency, history of pure diet iron intake, celiac disease, Crohn's disease, disease of gastrointestinal tract with signs of internal bleeding. Also, it's maybe infection or pregnancy. Examination. Pallo, dyspnea, poor excessive tolerance, colonychia, angular glossitis, thinning hair, systolic flow murmurs, hemorrhoids, fresh blood, or melena, or rectal examination, evidence of pregnancy, adnexal mass, or fibroids. Laboratory tests, CBC with peripheral smear, tissue transglutaminase, immunoglobulin A tests, and total immunoglobulin A tests. Fecal immunochemical tests. Other tests include upper gastrointestinal endoscopy, colonoscopy, CT colonography. Also flow cytometry and transvaginal ultrasound. Stool microscopy and Helicobacter pylori tests. Vitamin B12 deficiency, history of celiac or Crohn's disease, autoimmune thyroid disease, gastric bypass, chronic antibiotic use, vegan diet, or alcohol misuse. Fatigue, palpitation, distal paresthesias, depression, confusion, tinnitus, dementia. Examination, impaired vibration cells and extremity numbness, vitiligo, glossitis, poor balance of coordination, tachycardia, pallor, hepatosplenomegaly. Laboratory test, CBC with peripheral smear, serum vitamin B12 levels usually is low. Serum methylammonic acid levels, anti-intrinsic factor antibodies, tissue transglutaminase, immunoglobulin A tests, and total immunoglobulin A tests for indication of celiac disease. Folate deficiency, also this disease associated with gastrointestinal tract may cause folate deficiency, and the main symptoms are fatigue, palpitation, headaches. Examination, mild persistent pyrexia, tachycardia, pallor, hepatosplenomegaly, glossitis, angular stomatitis, partial hyperpigmentation of skin and mucous membrane. Laboratory tests, CBC, serum vitamin B12 levels, serum folate, and also serum homocysteine levels. Myelodysplastic syndrome. It's different toxic hazards. Symptoms: fever, chills, fatigue, weakness, recurrent infection, anorexia, night sweats, shortness of breath, easy brushing. Examination, pallor, petechia, purpura. Laboratory tests, CBC with determinant of reticulocytes count, and also bone marrow aspiration and biopsy. Also serum vitamin B12 level, folate level, acquired aplastic anemia, history of hepatitis, HIV, benzene exposure, use non-causative medication, radiation exposure, paroxysmal nocturnal hematoglobinuria, malaise, symptoms: malaise, fatigue, easy brushing or bleeding, recurrence, infection, fever. Examination, pallor, petechia, purpura, dyspnea, tachycardia. Laboratory test, CBC with peripheral smear, bone marrow aspirate and biopsy. Serum vitamin B12, folate level. Anemia of chronic disease, usually a history of known chronic inflammatory autoimmune or infection states, sustained physiological stress, renal failure, liver disease, heart failure, hypothyroidism, vasculitis, or collagen vascular disease, inflammatory bowel disease, hypogonadism, poor exercise tolerance, anemia correlated with severity of inflammatory process. Examination, pallor, fatigue, dyspnea, specific signs of underlying disease. Laboratory tests, CBC, serum iron studies, serum erythropoietin level, history autoimmune disease, systemic lupus erythematosus, rheumatoid arthritis, scleroderma, lymphoproliferative disorders, recent viral illness, or mononucleosis may be asymptomatic. Symptoms include weakness, fatigue, headache, poor exercise tolerance, prayer gallstones, dark urine, clay-colored stools. Examination, pallor, lethargy, dyspnea, tachycardia, jaundice, splenomegaly, especially if intravascular hemolysis. Laboratory tests: CBC with peripheral smear, lactate dehydrogenase, haptoglobin, direct antiglobulin Coombs test, serum bilirubin. Other tests: antinuclear antibodies, dsDNA Smith antigen, rheumatoid factors. Thank you for your attention.